Alright, so we're starting our second lecture for patient assessment. So this would be day 2, and this would be for Monday, July 27th. So we're talking about cardiopulmonary symptoms, and this goes along with Chapter 3 in Wilkins and Chapter 16 in Egan's. They're both really good resources to look at. Alright, so you're going to think that we're kind of crazy how much we can talk about cough and sputum and chest pain and shortness of breath, but it's all very important as part of our assessment. Okay, so when our patient has a cough, it's one of the most common symptoms in patients with pulmonary disease. Our cough is very important. It's a very protective reflex. It helps us from aspirating. And there's different receptors that are located in the pharynx, so the back of the throat, the larynx, around your voice box, your trachea, your large bronchi, and your lung and visceral pleura. So we need to pay attention to a cough. Number one, we really want to know why we have a cough, how long we've had a cough, if it's a productive cough, and if it's an effective cough. Okay, so coughs are often impaired with patients that have like a neurologic or neuromuscular disease. So their cough is not as effective. They're not able to clear their secretions as well. So like different weaknesses from, let's just say Guillain-Barré, muscular dystrophy, any type of spinal cord injury, neurologic, like a stroke patient. So these types of patients are at risk for aspiration. They maybe have lost their ability to protect their airway. Post-op patients, we really want to make sure that they're coughing effectively, especially those patients that have upper abdominal or thoracic surgery, mainly because it hurts and they don't want to cough, or any type of trauma, like a motor vehicle, motorcycle accident, a fall. These patients tend to not want to cough, not want to take a deep breath because of the pain. So pain management is very important so that we can help them cough. Alright, so there's these different, it's kind of like a stimulation, or no, actually I'm ahead of myself. So we're going to talk, it's coming up in a couple slides, the phases, that's what I was thinking of for a minute. So our cough is stimulated by something. Something is causing us to cough. So an inflammatory is related to generally an infection or an allergic response to something, allergies. A mechanical cough could be related to like dust, food, some type of foreign body obstruction, a tumor. So mechanical is something you think about maybe being able to remove, I guess. Chemical would be like inhaling fumes, gases, smoke. Thermal would be hot or cold. Sometimes cold air makes people cough. And then your ear, there can be tactile pressure in the ear canal. So what happens, it's mechanical stimulation of the external auditory meatus, M-E-A-T-U-S. Meatus can actually activate a branch of the vagus nerve and can cause a reflex cough. And that vagus nerve is also known as the Arnold's nerve. Okay, so just kind of a little trivia there. So this kind of basically sums up a lot of what I just mentioned. This comes from Wilkins in Chapter 3. Okay, so what is the most common symptom of pulmonary disease? Well, what we've been talking about in the picture of what that lady's doing, cough would be your correct answer there. 4 phases of cough, and Wilkins actually says 3 because they don't really start with the agitation, they start with the inspiration part. So obviously there does have to be some type of agitation, which we talked about, that's going to stimulate you to cough. Okay, so there's some type of stimulus that occurs, and then you have these phases of cough. So in inspiration, you have an open glottis, the diaphragm contracts, meaning it goes lower when it contracts, which then allows you to increase your lung volume, and it also increases the length and caliber of the bronchi. Okay, so we have this inspiration. I'm just going to repeat it again. Your glottis is open, your diaphragm contracts, so it actually moves down. Okay, so it's no longer dome shape, it kind of flattens out, which then allows the lung volume to increase and the length and the caliber of the bronchi to also increase. Then the compression part then is when the closure of the glottis and the relaxation of the diaphragm while the expiratory muscles contract against the closed glottis and create pressure, which then helps narrow the trachea and the bronchi. Okay, never really thought of it as detailed as this, I'm sure. So again, with the compression, the glottis is now closed. There's the relaxation of the diaphragm, and then while the expiratory muscles then contract against this closed glottis and create pressure, which helps narrow the trachea and bronchi. And then the expiration is now the glottis is open again. You have this explosive release of trapped pressure, and the vibration of your vocal cords and the mucosal lining of the posterior wall actually helps shake secretions loose. Okay, so like back in your oral pharynx, it'll help, and then the larynx area kind of help secrete near the vocal cords, kind of help shake those secretions loose. So again, you have the open glottis, this explosive release of trapped pressure, and then the vibration of the vocal cords and the mucosal lining of the posterior wall help shake the secretions loose. So quite the process there, I guess. So again, the effectiveness of your cough is dependent on the ability of a person to take a deep breath, and like I mentioned, that can be limited for certain people. Your lung elastic recoil, and so as we age and as the COPD process continues to decline your lungs, that's something that is lost, is the elastic recoil of the lungs. They start losing that ability. Expiratory muscle strength, and then the level of airway resistance. It also is kind of dependent on how much sputum and the type of sputum. So if you have a lot of sputum, you know, some patients fatigue, are just not able to cough all that stuff out. And then if it's really thick, we can actually administer mucolytics to help thin out the secretions to make it easier for them to cough. And then also we need to be ability for a person to take a deep breath is also kind of falls into like the category of like their level of consciousness. So whether they're, you know, physically not able to do it, or mentally they just can't do it anymore. They can't follow the directions, or they're just, their level of consciousness is too impaired. And then another thing that sometimes happens if you develop tracheomalacia, and that can happen sometimes with prolonged intubation. It can also happen more so with infants, premature infants, where you have an obstruction, or basically the collapsibility of your airway. That's what happens. So instead of, you know, being able to effectively cough step up, when there's those pressure changes happening, the actual airway will collapse, tracheomalacia. So the 4 phases then of cough. I'll let you take a look at that. So I'm hoping you're going to pick D. Okay, so you have something that's agitating. You have that inspiration, the compression where it's going to close your glottis, and then the expiration. Okay, you will see these questions again, these little questions. Okay, so when we talk to our patients and do part of our interview, we want to know what's going on with this cough. Is it an acute thing? Has it just suddenly started? Generally, it's pretty severe, like associated with like a pneumonia or an infection or bronchitis. URI is upper respiratory infection or allergies. So an acute is again defined there. Chronic. It's kind of interesting. It depends what resource you look at. Chronic is persistent, more than 3 weeks. I think that was Wilkins. Egan says 8 weeks. So chronic is just really not going away. It's generally associated with the lung disease, more so like COPD or bronchiectasis or something like that, or smokers. So it's not a sudden onset. And paroxysmal is kind of more periodic. It can be prolonged. It can often occur at night when patients go to lay down. That's usually due to heart failure. Aspiration can be described as paroxysmal or asthma. Okay. And then again, back to whether it's effective or not. I mean, these are actually things that we chart. If they have an effective, productive cough, if it's productive, then it's probably effective. If they have a weak cough, an inadequate cough, an ineffective cough, okay, you can hear the stuff, you can hear the secretions in there, but they cannot mobilize it. So that's definitely an area where we would intervene, and we have different tools to kind of help with that. We can give them a flutter valve. Sometimes if they just have something in there, that flutter valve creates a little bit of back pressure, kind of helps to open up the lower airways, gives them a little bit more oomph, I guess. That's a technical word. Helps them mobilize the secretions. There's also the medications as a mucolytics like Mucomyst, but that's kind of controversial, but I still sometimes order it. Just your hydration status. Humabid, which is an oral pill. Guaifenesin, I'm sure I always pronounce that wrong, but guaifenesin or guaifenesin starts with a G. That can help break down their secretions. Sometimes actually you don't see it used as much as you used to, but what we would do, chest PT. I mean, chest PT you'll still kind of see used. It's generally a bit more mechanical in the fact that we have like these little percussor things, these little, they look like, I always say they're like a little jackhammer. They're about the size of a large orange, I guess, kind of roundish, and they're pneumatic. You plug them into the gas source, usually air. Hold on one second. Don't eat that. I was trying to find something to chew on. I would love to chew on my other folders. And it's kind of like a little jackhammer, that pneumatic thing, and it kind of goes and you kind of put it on a patient and kind of manually or pneumatically claps on them. I'm kind of a big fan of the old-fashioned chest PT, and I'll show you guys how to do that. Of course, you'll also learn therapeutics, but when I used to work at a CF center, or if you work at university or children's, you hopefully will have the opportunity to do chest PT, which actually, I'm actually hitting myself right now. That's kind of the sound it makes. I can't get to do it as well. It's kind of more of a cupping sound. It works better on my leg. Anyway, that helps shake and loosen up the secretions if you know for sure that there's something there. And the other thing that I was going to mention was a cough assist. There are some devices that people kind of insufflation, exsufflation devices that they've made where a person puts the device in their mouth and it helps kind of push air in and kind of help suck it out. But if you actually, and I helped the gentleman with this probably about a couple of years ago now, but he was coughing and he had a paralyzed diaphragm, or one side of his diaphragm was paralyzed, or not moving as well. He was coughing and he just could not quite cough the stuff out. So I did a little chest PT on him, and then you kind of lay them somewhat flat if you can, and then you actually almost do like an abdominal thrust. So they're laying on their back, and you actually kind of take the palms of both of your hands, kind of put one on top of the other, and you kind of push up underneath their diaphragm, below their rib cage, and kind of help when they go to cough. You kind of give them that extra push. And it actually helped him. He's like, "Wow, you're the first person that's done that." But it's pretty old school, but it was effective in his case. He was able to cough up quite a bit of stuff. So the different devices, if we have to maybe NT section a patient, where we actually have to go down with a small tube, generally through their nose, and to actually suction the stuff out. So that's probably the most unpleasant thing that we have to do. And then if they have a non-productive cough, sometimes it's just a dry, non-productive cough. All right, other descriptions of coughing can include a barking cough. If you click on this little video link here, you'll see an example of a crooper, a kid that has croup. Kind of has like the circus seal kind of bark to it. It's often accompanied with stridor. So the stridor is a sound that's made generally of inspiration, kind of like that. And then when they cough, because everything is narrow and swollen, then they have this barky cough. They also like to look to see if you Google X-rays of the neck and do a steeple sign, you'll see that in kids where they have croup. So it's kind of one of the, you'll talk about that too in pediatrics, respiratory peds, but whether or not somebody has epiglottitis, or if they, oops, darn it, I touched my screen again, it's dust, epiglottitis or croup. The other type of way that you might describe a cough is a brassy or a hoarse kind of harsh cough, where you can almost, it just sounds kind of more tight. Wheezy is more high-pitched. Generally that's associated with like maybe asthma or pneumonia with secretions. And then the hacking cough is more chronic, generally from smoking, a COPD patient. All right, so paroxysmal we already kind of talked a little bit about. Generally at night, it can be associated sometimes with aspiration, and because it's associated at nighttime with a person lying down, it can often indicate heart failure. Obviously a dry cough, you're not going to produce any secretions. And then the productive cough, it again depends on a chronic productive cough. Again, we need to look at the cause. Generally it's saying that the patient produces phlegm for most of the days out of like 3 weeks, but it's been going on for a while. They might be on medications. ACE inhibitors sometimes can cause a chronic cough, again, so congestive heart failure. Lisinopril being one of those medications, or Lotensin. And then non-asthmatic can actually have eosinophilic bronchitis. There's no bronchospasm associated with it, it's just they have this cough. Now, of course, for the most part, a cough is a fairly good thing to be able to do. I mean, you want to be able to cough and move those secretions if you have to. However, there can be some complications associated with coughing. You can tear some muscles in your chest wall. If you cough hard enough, some people, especially elderly patients, may actually fracture ribs. Disruption of surgical wounds, the wound can dehiss, which means it bursts back open. I actually saw that one time when I was working at University in Wisconsin. I'll never forget it. It was a nurse was in a patient's room, and it was during the night shift, and she was bathing him, or I don't know what she was doing, bathing, maybe she suctioned him too or something. Anyway, he started coughing. He was on the ventilator, and all of a sudden she's like calling for help, and we all run in there, and his wound dehisced. It just like popped back open. It was an abdominal wound, and she was basically holding his intestines in her hands, trying to get, he had to go back to OR obviously, but that was pretty sick. You can also have a pneumothorax or pneumomediastinum with, again, a complication of a cough, where you could collapse part of your lung down. A syncopal episode that is stimulated the vagal response, so you basically pass out, kind of coughing really hard, you increase that intrathoracic pressure, and it can actually stimulate your vagus nerve. Esophageal rupture, I mean, these are pretty rare, and urinary incontinence. Alright, so here is just kind of defining the difference between sputum and phlegm, and I think it's kind of funny because I've never really have had anybody really say, you need to get a phlegm sample instead of a sputum sample. We just generally call it sputum. But for testing purposes and for exam 1 in your test, you do need to know the difference. Okay, so sputum is defined as the substance expelled from the airways, mouth, sinuses, and nose by coughing or clearing your throat. Where phlegm refers strictly to the secretions coming from the tracheobronchial tree. But like I said, when we do even bronchoscopies, when we're actually going in there with a scope and they're getting a sputum sample, I don't think I've ever heard them say a phlegm sample. But just so you know, I'm going to include this lovely slide of the differences. Alright, so we love sputum. Respiratory therapy is, generally it's a thing where nursing cannot stand sputum, and respiratory, we're really not into poop. But and it's funny because nurses usually, the poo doesn't bother them, but the sputum usually does, so it's kind of funny. But when we talk about sputum, so again, we want to, we're talking about the cough and whether it's effective or ineffective and what we need to do with intervention. We want to be able to describe the sputum, okay, because that can give us an idea of what's going on. It's part of the piece of the puzzle, okay. So yes, you do have a cough. Yes, you do have a productive cough. What color is it? What's the consistency? Frothy. We kind of saw a little bit of frothy, like pulmonary edema stuff in the sheep lungs or the lamb lungs, that kind of like bubbly stuff. Thick, tenacious. Okay, so tenacious is very sticky, hard to clear. So that's kind of describing the consistency. Quantity, okay, how much are they coughing, how often are they coughing. So believe it or not, a normal amount of sputum that we produce every day is about 100 mils a day. Okay, so it seems like a lot, but we just don't even really realize it. It's just kind of hanging out back there in the throat. I mean, you just have that natural secretion, and that's good. You need to do that. That's what's helping prevent you from getting sick. Sometimes sputum will have an odor. Not that I go around smelling people's sputum, but sometimes it's unmistakable, especially suctioning a patient. Pseudomonas is probably one of the worst ones. It's a nasty, like sweet, rotten smelling crap. And then we also want to know if there's any blood. So for definition, fetid is very foul smelling. Okay, so foul smelling, fetid. If you had foul smelling sputum, it's most likely some type of an infectious process. Sputum really should not smell. So again, remember your sputum is just kind of moved every day by that mucociliary escalator until it's swelled. So that's kind of where that 100 mils is happening. I mean, you have that mucociliary escalator always there, and I think you probably learned that, I think, in A&P. But you know, that's a normal process. It's when your mucociliary escalator doesn't work very well, as for example, smokers in that you end up having trouble, and you end up having to have difficulty coughing up secretions. A lot of times those patients, once they have quit smoking, obviously in the hospital you can't smoke, so if they've been admitted for a couple of days, they'll sometimes say that, you know, I haven't been coughing up this much stuff, you know, now that I quit smoking, I'm coughing all the time. Well, that's because the mucociliary escalator, the little cilia, are kind of coming back to life. They've been kind of beaten down by the tar and the nicotine and the different toxins, and so you've kind of disabled it. But by stopping, quitting smoking, it's enabled again, and it's doing its job by clearing those secretions. All right. So we may have excessive sputum, might be caused by inflammation of the mucus secreting glands that line the airways, those goblet cells, and different sources of inflammation, infection being a fairly common one, smoke, allergies. Again, dehydration can make thick sputum. It's generally more clear. The pink frothy is again consistent with pulmonary edema, and then the thick purulent meaning pus containing, is generally indicating infection. So you want to kind of, when you're interviewing your patient, you know, maybe they always have a cough or whatever, depending, you know, what's going on with them, but now it's changed. Okay, it's changed in color. Hold on one second. So we really want to be aware of any of those changes that are going on. This is out of chapter 3 again, just kind of talking about what some of the different colors of sputum and what it could possibly indicate. Okay, one of these that I know for absolutely sure is your purulent apple green thick sputum. That will actually be on a test, and it is Haemophilus influenza. Okay, so try to be familiar. I mean, your clear colorless, like an egg white, is pretty normal. Black, I mean, that would be kind of smoke or coal. Brownish can be sometimes that nicotine. The frothy pink is pulmonary edema. Sand or small stone. Aspiration of foreign material. Bronchial lithiasis. That ending of that word actually means stones. It's like a chole, like a, what am I thinking? Gallstones, chole, C-H-O-L-E, and it'll have that ending, that suffix, I believe, yeah. Is a kidney stone, or actually both, gallstones, kidney stones, whatever, it means stones. So your purulent, kind of, you know, be a little more familiar with what the causes of that can be. So your apple green, again, Haemophilus influenza, more pink, thin, blood streak, could be pneumonias like streptococci or staphylococci, whatever. Red currant jelly is generally Klebsiella. Rusty could be pneumococci. The yellow or green, different types of Pseudomonas. Again, Pseudomonas with CF is really quite a little bit more smelly. What else was I going to say? Oh, yeah, bronchiectasis. I'm trying to see. I think it's going to be in this class. You'll see there's a picture of sputum. Bronchiectasis has more of that layered. You'll see, like, it's a picture, it's a photo, and I don't think it's on today's lecture, but it's It's like a layered stuff. It's like almost like foam on the top. It's disgusting. Foam and then like a middle layer, then kind of like a thick sediment, like the pussy, nasty layer. And then your mucoid, emphysema patients. I just know for sure the purulent ones are definitely ones you want to focus on for your exam. Grayish for Legionnaires, silicone cast, like casts. I know Victor's seen a few different casts with different disease process, but it's pretty rare to actually get them out. And that could be asthma. And then obviously really blood-streaked or hemoptysis, like frank bloody, that's often an indication of cancer, sometimes TB. Occasionally it could be pulmonary contusions, like a bruise in your lungs, basically is what that means, or an abscess could have happened, or maybe your coags, your coagulopathy, your blood thinners or something. All right, so how much mucus does a normal person produce in a day? This little cup here should give you a clue, the top number. So hopefully you picked C, 100 mils a day. Back to talking about hemoptysis. So again, some of the different causes. Kind of mentioned some of these already. Persistent coughing after a while. You might break some blood vessels. And defined, so streaky is kind of more blood tinged. It's not necessarily like massive blood. Massive refers to more than 400 mils of blood in 3 hours, or 600 mils in 24 hours. So hemoptysis, you know the definition of hemoptysis. Make sure you know these numbers. So 400 mils in 3 hours, or 600 in 24 hours. All right, kind of another little slide there, just kind of talking about some of the different, more of the frequent causes of hemoptysis. Again, chapter 3 in Wilkins. Acute bronchitis with severe coughing. Again, cancer, sometimes bronchiectasis. These are potential causes for massive hemoptysis, chronic bronchitis, TB, and then some of the less frequent causes, pulmonary-related ones, cardiopulmonary, more systemic things, and other pseudohemoptysis. Oh, yeah, definitely make sure it's not coming from the mouth. Sometimes people get confused because they gag and cough and puke at the same time. You might think it's coming from their lungs, where it's actually coming from their esophagus. So it could be actually, what I want to say, emesis. Okay, like a GI bleed, because that's what I was thinking. All right, so like I just said, that make sure it's coming from the lung, not the stomach. Obviously, blood from the lung is generally associated with pulmonary problems, and blood from the stomach is associated with GI. So it's important to differentiate. All right, so what about that apple green sputum? What does that cause again? I hope you're thinking of the right answer. It would be Haemophilus influenza. So you will see that question again. Dyspnea, okay, dyspnea, or shortness of breath, is a common symptom of patients with lung or cardiac symptoms. It is considered the most distressing symptom of pulmonary disease. So, and it also, this is kind of funny because, chest pain, but dyspnea is considered a cardinal symptom of cardiac disease. And I'll talk about chest pain here coming up in a few slides too. It depends what source you look at, which book. Just keeping in mind that, and the reason I have just a little story about the cardinal symptom of cardiac disease is that when my father-in-law had his heart attack, I think it might have been his first one, he was just, totally convinced, and I was telling the paramedic, it is not my heart. It's not my heart. I just can't breathe. I'm short of breath. I can't get my breath. I can't breathe. And they're like, no, sir, we're pretty sure you're having a heart attack. So, which he did, and he has since had bypass surgery and that. But anyway, so it is definitely a cardinal symptom of cardiac disease. So we really need to pay attention to shortness of breath or dyspnea. We need to pay attention to it and figure out why the patient is experiencing it. So again, it's a subjective complaint that varies with whatever's causing it, and psychological variables too. So just, if you're short of breath, you're going to probably become anxious and that. And so, you have to definitely investigate it and figure out what it's coming from. So it's kind of like one of those pain things. I think I mentioned that before, that we can actually rate on a scale. And everybody perceives it a little bit differently, just like pain. So we have to pay attention to the work of breathing. Seeing it's abnormally high for that given level of exertion. Is it related to asthma? Is it related to pneumonia? Is it related to a neuromuscular disease? So the vital capacity, the actual ability to take a deep breath, is definitely diminished. Okay, we also have to pay attention. What is their drive to breathe? Is it related to being low with oxygen? Is it an acidosis, where they have a respiratory acidosis? Is it, or even a metabolic acidosis actually? So we're trying to offset. So that would be where our drive to breathe is increased if it's a metabolic acidosis. So then we are trying to compensate by breathing faster. Is it related to exercise? Okay, so during our interview, like I mentioned before, you need to, is the patient able to speak in complete sentences, or do they have to pause? You may even see charting or someone in report referring to 1 or 2 word dyspnea. So what that means is after they have said 1 or 2 words, they basically have to take a break so they can breathe again, and then or 2 or 3 word dyspnea. So just kind of keeping in mind. Here was that scale that I was talking about, 10 obviously being the worst. So if somebody's having a hard time kind of quantifying their dyspnea, you can kind of give them a 0 to 10 thing, 10 being the most severe, and then hopefully again after some type of therapy or intervention, you're able to relieve the dyspnea. So this is just looking at different types, clinical types of dyspnea. So it's kind of really examining it a little bit further. So obviously you have physiologic, that might be due to exercise, or acute hypoxia, like you're at a high altitude, or maybe you're breathing high concentrations of carbon dioxide. So you have more of an awareness of your increased ventilation. You're feeling that you're breathing fast. As far as more pulmonary, restrictive, including all these like pulmonary fibrosis, chest deformities, pleural effusion, pneumothorax, those are all considered restrictive processes. These people are generally comfortable at rest. Intensely dyspneic when exertion nears the patient's limited capacity, so they can do so much, but if you kind of push them over the edge, then they really have, they're really quite short of breath. An asthma patient, more obstructive, they actually just have an increased ventilatory effort. It just takes them more to take a breath. They often have dyspnea at breaths, because COPD or obstructive emphysema and asthma sometimes physiologically are similar. They have labored breathing. They may have a prolonged expiratory phase, so they kind of do that pursed lip breathing thing, or they make a forced expiratory pattern, so they're inspiratory to expiratory. That's another thing you'll learn about your I/E ratio. So your inspiratory to expiratory ratio generally is like 1 to 2. It's kind of normal. but for these patients that have obstruction or asthma, they'll have a prolonged expiratory. They just have kind of lost that recoil, so they have to kind of force the air out. If it's associated with heart failure, they need to sit up to breathe. It's hard for them to lay down at night. If they have chronic anemia, or if they're bleeding, like hemorrhaging, circulatory, air hunger, that's kind of like almost like a guppy breathing kind of thing, where they kind of gasp for air. Head injuries are pretty common. Oh, I skipped that one. Chemical, like kidney failure, so if you have an acidosis going on, heart failure, they're kind of more panting, fast breathing, rapid breathing. Head injuries can sometimes cause hyperventilation, different lesions in the brain. And then again, it could also just be pain related. Hysterical overbreathing is like in a panic attack. So trying to help differentiate what's going on. All right, so then we have acute and chronic. So be familiar with which category. Asthma can be both. I mean, they can have an exacerbation, so basically they have asthma, they're chronically short of breath, but certain things can make it worse, like an infection or an exposure or something. Chest trauma, obviously being acute, physical exertion, pneumonia, infection, pulmonary edema, a blood clot, spontaneous pneumothorax, where on the right side there you have, again, asthma. They may have like a baseline, and the same thing with the COPD. It can be an acute exacerbation. That's definitely a diagnosis, like admitting diagnosis, and it is an acute exacerbation of COPD. And it's generally an infectious process. That's the acute part of it. Chronic with heart failure, cystic fibrosis is what the CF is, pleural effusion. They have reaccumulating pleural effusions, interstitial lung disease, and pulmonary hypertension. These again are kind of similar, a little bit more related to that other slide that I just talked about. Causes kind of broken down more so by body system. So we can go ahead and take a look at those. Again, we're really trying to figure out what's going on, why is somebody short of breath. So we have all these questions to help us put the pieces of the puzzle together. So for example, if you are short of breath, is it related to a cough? Do you get more short of breath when you're coughing, or does the shortness of breath make you cough, or what comes first? Chest pain. Do you have chest pain along with the shortness of breath or the dyspnea? How does it limit your activity? Are you stable to do your ADLs, your activities of daily living? And that's one thing that like pulmonary rehab is really helpful for. It can actually give these patients different tools to use so that they can bathe, change their clothes, do whatever, make their bed, all that kind of stuff, cook, and even OT helps with that, and to help these patients so that they can get done what they need to get done without being extremely short of breath, to help conserve their energy. And different exposures, chemicals, smoke, illnesses, that type of thing. This is like kind of talking about the language of dyspnea. So we should try to be able to recognize different aspects of the breathing, including the inspiratory part, the expiratory part, their respiratory drive, or how well they're able to take a deep breath. So different things that might help us figure out what's going on with the patient is when they're describing their dyspnea. So patients with asthma might say they really are having chest tightness. Patients with interstitial lung disease may complain of increased work of breathing. It might be shallow, so rapid shallow breathing, kind of more gasping. Patients with CHF may complain of feeling suffocated, so that might be due to all the fluid that's kind of backing up into their lungs. So these are just kind of like generalizations. I think I found this in the book, The Language of Dyspnea. Patients with cardiopulmonary disease generally have both of these things going on simultaneously. So, you know, the heart and the lungs work together, and so sometimes it can be a little bit of both. So, you know, trying to differentiate, you know, again, like CHF, it's your heart, but it's also backing up into your lungs. So, just book real quick. So it's helpful to, you know, try to figure out what exactly is going on. All right, yeah, both of these books are really helpful. I'm just kind of looking at this really quick. I was trying to figure out where I found The Language of Dyspnea. But look at 3 in Wilkins and what was it, 14 in Egan's. Or no, 16, sorry, 16 in Egan's, 3 in Wilkins. So, back to some little review questions again. What is the cardinal sign of heart disease, dyspnea? And which of the following is an acute cause of dyspnea? I'm hoping you're saying pneumothorax. All right, another just a screenshot kind of the Borg scale, modified Borg scale. This is out of chapter 3 in Wilkins. Make sure you're familiar with these terms. The next couple pages are going to have different terminology. So apnea, meaning cessation of breathing, you're not breathing anymore. Eupnea is normal. Brady, always remember, is slow or decreased. Tachy being fast or increased. Hypopnea is decreased depth or shallow breathing. Hypopneas are something that they measure when they do a sleep study, how many hypopnea events they have. Hyperpnea, increased depth. Platypnea is you actually have dyspnea while sitting up, and that can actually be caused by a patent foramen valley, so the heart defect. Orthopnea is pretty common. People complain of being short of breath when they're reclining position, so when they're laying down. Sometimes people have to sleep with pillows. They may say like 2 or 3 pillow orthopnea, so that helps relieve that sensation. Common again in CHF patients. PND is paroxysmal nocturnal dyspnea, again common in CHF due to the pooling of fluid in the lungs. Hyperventilation really would have to be an increased alveolar ventilation, which would have to be verified by an ABG. So your CO2 would have to be below like 35 to be considered true hyperventilation. And then hypoventilation would be the opposite, where your CO2 would be greater than 45. This again is just another terminology chart out of chapter 3. Let me just looking. A couple different terms are on here that weren't on the previous slides. Tripopnea, dyspnea in one lateral position but not in the other. So let's say you had a pleural effusion or a pneumothoraces or something that hadn't been diagnosed, or a tumor or something, so you're more short of breath lying on one side than the other. Actually, you know, when I'm thinking about that, my sister, I think, kind of has that, because she has that post-polio, and she has kyphoscoliosis, so she has a curve plus the hump. She's got both kind of going on. So with the post-polio, she has a lot of kind of chest wall deformity, and I think one of her lungs is actually smaller than the other just because of the chest wall. So she has tripopnea. Orthodeoxia Arterial sat that is produced by assuming an upright position. Oh, that's, yeah, I think we already kind of talked about that. No, not really. That is produced by assuming an upright position and relieved by returning to a recumbent position. Okay. And then air hunger being a grave sign, kind of almost like a kind of that guppy breathing kind of thing we call it, kind of where they just kind of gasp. All right. Which of the following breathing patterns is associated with shallow breathing? Shallow breathing, something that they monitor during sleep studies. I think it's kind of a fun word to say, hypopnea. Hypopnea, you should pick D. Alright, chest pain and dyspnea are considered both considered a cardinal symptom of heart disease. One of your books states both. I think it's Wilkins. So the biggest thing then is trying to differentiate where that chest pain is coming from. It could be both, but definitely cardiac needs fast intervention. So you may have chest pain in patients with lung disease when the pleural lining is abnormal, because that's what's going to cause more of the pain. So again, taking a thorough history in your patient interview and your examination are definitely important. And chest pain needs to be taken seriously. So if they really think it is related to cardiac, the first thing they're probably going to do is get an EKG and then draw some labs. All right, so causes of chest pain. So cardiac ischemia obviously can be a cause of chest pain. The thoracic wall is the most common source of chest pain. Okay, so your inflammatory disorders of the thorax and the abdomen. But I have an added note here that the thoracic wall is the most common source of your chest pain. Musculoskeletal disorders, trauma, anxiety can sometimes cause chest pain. Referred pain from indigestion, or possibly a dissecting aortic aneurysm, hopefully not, because that's usually pretty deadly. So the cardinal symptom of coronary artery disease is angina. So make sure you know that. Cardinal symptom of coronary artery disease is angina. So generally, chest pain caused by pulmonary disease is usually more so of the pleural, the chest wall, or the parietal pleural. You really don't have so much other than like cough reflexes, pain per se in your lungs. It's generally the chest wall or the pleural area. Pneumonia, lung abscess, pulmonary infarction often involve overlying pleura and induce pleuritic chest pain. So so some of the different pulmonary causes of chest pain, and this is when involving the chest wall or the parietal pleural, not the heart. So this isn't related to the heart. So when you're looking at, so both of these, looking at pleuritic pain and chest wall pain, are not caused by the heart. Pleuritic pain can sometimes be caused by infection or trauma. Usually it's located laterally, meaning along the side, or in the back. It's often associated with inspiration. It can be sharp and abrupt onset. Again, worsens with inspiration, like a cough or a sneeze or a hiccup, laughter. It increases with pressure and movement and is generally caused by inflammation or trauma. And then the chest wall pain then is like, I would say, then that's more intercostal related to your muscles, your intercostal and pectoral muscles, and it's well localized. So it's kind of like in a certain area. You have pleuritic pain and chest wall pain that are not associated with cardiac. So chest pain then from heart disease should present a little bit different, but you know, people have a really hard time describing things sometimes. So they may say it's kind of more achy, squeezing, pressing, a vice-like, an elephant sitting in your chest, often increases with exercise. So, and remember, women actually sometimes present with a little bit different types of pain. It might be more in their neck or in their arms or in their back. I know a nurse I used to work with at Lutheran, she just felt kind of not well for like a week. She just felt really run down and kind of weak and kind of was a little bit nauseated, but they ended up finding out that she had an MI. She didn't really have the real typical chest pain that you would normally associate with a heart attack. So then the pleuritic chest pain then the patient often will lead to one side. They'll report it as being stabbing or burning, and again worsening with a deep breath. So the different things that you want to make sure that you're asking your patient when you're doing your interview are trying to be as specific as possible. When did it start? Where is it at? Does it radiate? How often do you get it? How long have you had it? How bad is it? On a scale of 0 to 10, are there things that make it worse, things that make it better? And trying to describe the type of pain. A few more different terminologies here. Again, syncopal or syncope is a temporary loss of consciousness, generally caused by a reduced, oh my goodness, hold on 1 second, the dog's doing something crazy. Here. Sorry guys, I hate having to do that. So they kind of pass out, basically they reduce blood flow and oxygen to the brain. There's several different things that can cause it. The different types of clots in your head, different embolisms, clots in your lungs. What else here? Sometimes coughing, really prolonged bouts of coughing. The vasovagal is the most common type of syncope. They lose the loss of peripheral tone. Again, sometimes it's associated with people sitting on the toilet. So a lot of times patients will have a syncopal episode after they've been using the restroom. We'll often get called to people that have passed out coming out of the bathroom or on the toilet. Some other causes of syncope, again out of chapter 3. Like I said, there can be many different causes. So take a look at those. Edema, peripheral dependent edema. Okay, so that's swelling, dependent meaning it's gravity dependent. Peripheral edema can be caused by chronic lung disease. So you think about hypoxemia, actually in the lungs, causes vasoconstriction, which then is going to require the right ventricle to work harder, so it's going to increase that afterload. It's going to have to push against the constricted vessels, so it's going to make the right heart work harder, and then as that progresses and keeps going on, the right ventricle becomes enlarged and eventually is not able to pump all of its blood to the lungs, and then this results then in the venous system to dam up and become engorged, and then the high pressure in the veins push out the extra fluid, pushes out into the tissues, especially the gravity dependent areas. Okay, so it's just kind of like just a backup of this fluid. So you think of chronic lung disease, again, vasoconstriction increases that afterload. The right heart has to push way too hard, After a while, it becomes overworked, it becomes enlarged, becomes less effective, results in the venous system to dam up and become engorged, and the high pressure in the vein pushes fluid out into the tissues, especially gravity-dependent areas. So you have edema, pitting edema. So you can kind of see here, you end up pushing there on that left foot, the person's left foot, and the little indentation there is pitting edema. Generally, if you're looking at edema, you're trying to evaluate whether it's in both legs. So if it's in both legs, then it's generally heart. If it's in just one side, unilateral ankle edema, then you're looking at the possible cause of being a blood clot or a deep vein thrombosis. Okay, so that's going to present with some swelling. Looking at this photo, the person's left leg, left calf, there's swelling, they're going to have pain. It's going to possibly be warm and red. So we want to make sure that they get treated so that doesn't travel. Last couple slides here. Talking about headache, altered mental status, and personality changes. So trying to associate what might, or trying to figure out what's going on if a person complains of like a headache in the morning. Headaches can happen from cerebral hypoxia and hypercapnia, from lung disease and high altitude, so even at high elevation you might get a headache. Altered mental status, obviously if you have a high CO2 level, hypercapnia. Personality changes can occur in these people in advanced pulmonary disorders. If these things progress for a long time, if they continue to have cerebral hypoxia or hypercapnia, sometimes they might display forgetfulness, inability to concentrate, kind of anxiety, irritability. And then the other thing that we need to consider, and it's actually kind of part of the nursing when they do their admission note, they actually kind of do like a little screening. They ask a couple different questions, and it's kind of interesting because then it automatically flags an order for us to see if they're on like OSA, obstructive sleep apnea, like alert type of thing. So if they score a certain score, I forget what it is exactly. I mean, every facility would be a little bit different, but I mean, some people have been truly diagnosed with OSA and they use CPAP at home, but for those that haven't really been diagnosed yet and they score high enough on this questionnaire, then if there's, they're suspecting that they might have it, then we put them on a continuous pulse ox. So they put a pulse ox on and the telemetry room reads those all the time, and then they kind of watch for any type of nocturnal desats. So we want to make sure, it's very serious if these patients have apnea during sleep. So we might need to do a sleep study on them, or at least a desat at night. You'll find out the difference about those as we go on. Especially can be associated when the patient is sleepy during the day. This actually occurs in about 10 to 12% of children. So I have a friend of mine who's actually I think he's the manager now of the sleep lab at Children's. So we were actually able to get some of our students into thinking that they wanted to work sleep at Children's to kind of job shadow. Now, of course, with COVID, that's probably all changed, but 10 to 30% of adults occurs twice as often in men. The average age is about 50 to 59 in men, 60 to 64 in female, and obesity definitely contributes because they kind of have that thicker neck and more of a tissue obstruction. Okay, that's a lot of material, and we will talk next time.